little bit. And then the director of NIDA, the National Institute of Drug Abuse, Nora Volkow, has also recently published an article about how academic medicine should contribute to solving the problems associated with the opioid crisis. And most importantly to us, I think, is that Kevin Mahoney, our CEO of our health system, recently mentioned how we really need to extend more care opportunities for patients with mental health and opioid use disorder in our community. So I think with that backdrop, it's really a great time to welcome an expert from across the country. One of the huge benefits of COVID is our ability to meet virtually, and we're really taking advantage of that. So Dr. Linder is a associate professor in the Division of Hospital Medicine and the Division of Addiction Medicine in DGIM at Oregon Health Sciences University. She has led the foundational work for addiction medicine consult services there and is really leading the change that's needed in hospitals around the country to enhance care for patients with opioid use disorder and really other substance use disorders. So she's going to talk to us about a little of those things, but you should know she's been recognized as the American College of Physicians Hospital's top doc, spoken at the National Academy of Sciences, and really her research that's been published in journals including JAMA, Annals of Internal Medicine, JGIM, Journal of Hospital Medicine, and the Journal of Addiction Medicine is the foundation of much of the analysis that we're trying to use to support an addiction service. So thank you so much, Honora, and hopefully we'll have time for questions.
Thank you so much. It's really a pleasure to be here with this wonderful group, and I've had the privilege of speaking with Dr. Perrone and Dr. Thakrar and others about some of the work that you're all embarking on, and again, just so happy to be here. I will, and thank you for the invitation. So I'm going to go ahead and share my screen. My hope is that I'll have plenty of time for questions, and looking forward to a rich discussion. So my topic today is talking about integrating addictions care in general hospital settings and sharing the experiences and lessons learned from our experience at OHSU, or Oregon Health Science University. And I'll use the acronym IMPACT, or Improving Addiction Care Team, which is our addiction medicine consult service. So just as I have no disclosures, as an outline, I'm really going to start telling you about my story and a patient who represented a lot of the challenges that I saw when I started doing this work back in 2012, and then talk about how my story has changed OHSU's story, and eventually we'll talk about how my hope is that OHSU's story will continue to change the national story. So this is a photograph not of a patient that I cared for, but of a young woman named Madeline Linsemeyer, who died of complications of opioid use disorder. And I read her obituary and recommend that folks read this piece by her sister that's really quite beautiful, describing a young, vibrant woman who died from this terrible disease. And the obituary and this photograph reminded me of another young woman who I cared for. And my patient I met in the fall of 2012. She was a 23-year-old woman who was readmitted to the hospital under my service and presented with chest wall pain. And when I met her, she had had a diagnosis of endocarditis in the setting of intravenous heroin use. She had been treated over the summer with 6 weeks of intravenous antibiotics that were all administered in the hospital. She then subsequently underwent aortic and tricuspid valve replacement and was then discharged to a skilled nursing facility, again, a very long hospital and post-acute care course. And when I met her, she had persistent chest wall pain, and she was readmitted to the hospital. And during the course of my caring for her, she met with social work and was encouraged to enter residential treatment. Our team had conversations with her about managing safe opioids. At the time, I really didn't have the expertise or knowledge to offer her or initiate medication for opioid use disorder, and that did not happen throughout her repeated hospitalizations. And it was clear to me that she, there was such a reciprocal sense of desperation. She was grieving the recent death of her boyfriend, who died of an overdose, really had pretty limited engagement during her hospital care. And unfortunately, we really were not equipped to treat her primary disease, her opioid use disorder. at tremendous cost if you think about the costs of these 3 long hospitalizations. And then several months after I cared for her, I learned from a colleague in the ICU that she had died after suffering a PEA arrest, and had an ICU course but died with family at her bedside. And so, I share her story because her story really motivated me to recognize these enormous costs. And she was representing a trend that felt like we cannot look away from this problem. And so I share data that at the time were not yet published, but that showed, over the last several decades, we really have had rising rates of hospitalization related to opioid use disorder and substance use disorder in general. And this is a trend that continues to rise amidst the crisis that we're in. And we also know, again, that substance use disorder drives rising costs. It drives rates of hospitalization, readmission, long lengths of stay. There are data from 2017 showing that there were over $13 billion in U.S. ED and hospital costs related to substance use disorder. And again, despite this frequent and costly acute care utilization, most people are not engaged in addictions treatment when they're admitted to the hospital, and most hospitals are not delivering this care. We also know that there's very high morbidity and mortality from substance use disorder. This is data from a study that our team published recently where we looked at all hospitalized patients with Oregon Medicaid and looked at people with opioid use disorder. And what we found was that 7.8% of hospitalized adults with opioid use disorder died within a year of discharge. That's a pretty staggering number when you compare mortality to other common conditions. So, for example, post-hospital acute MI mortality is 5 to 9% in the literature. The other thing that we found was that of those people who died, only 13% died of overdose. And so, as I commonly say, critically important, but overdose really represents the tip of the iceberg. And we found that of those people who died, 45%, again 13% being a piece of that, 45% died from drug-related causes, and the other 55% died from non-drug related causes, cardiac disease, pulmonary disease, cancers, etc. Again, really making the case that it's so important to integrate addictions care into general medicine settings and into hospital settings. So we know, and this is likely something that this audience may know, but we know that medications for opioid use disorder save lives. In the year after non-fatal overdose, when we compare people who were on medication for opioid use disorder compared to not, methadone maintenance was associated with reduced all-cause mortality and an adjusted hazard ratio of 0.47. Buprenorphine is associated similarly with reduced all-cause mortality and adjusted hazard ratio of 0.63. There are decades of evidence that support the effectiveness of these medications. I really appreciate a commentary by Elizabeth Poorman last year that really highlights that this mortality difference is more for medication, is more than antihypertensives, more than diabetics, more than statins, more than aspirin after an ST elevation MI. So I think we need to start asking ourselves, why are we not treating this disease? And hospitals have been slow to respond, and hospitalization often addresses the acute medical illness, but not the underlying cause. We also have more and more data showing the effects of this. So this leads to untreated opioid withdrawal and pain. It leads to patients avoiding or leaving the hospital and patient-directed discharges, and it leads to a missed opportunity to offer a life-saving treatment. So again, this was sort of the context and the beginning for my story, which really started around the distress that I felt and the missed opportunity for this young woman. And now, and I've peppered throughout my talk a few Oregon pictures, hoping to lure some of you out to come visit us. This is the OHSU tram looking out over the city. And just a little further off to the left, you get a big view of Mount Hood. Anyway, really how my story changed OHSU's story. So back in 2012, when I was working and thinking about these issues, even the opioid epidemic was really not on the radar the same way that it is now. And certainly it was not on hospital leadership's radar. And so before developing our consult service and before implementing these changes, I felt like it was really important to understand what did patients want and was hospitalization a reachable moment. It was possible that we were seeing this terrible morbidity and mortality, but maybe patients didn't want treatment in the hospital. And so understanding the patient perspective really was our first step. So we led a needs assessment of 185 hospitalized adults from September of 2014 to April of 2015. And we surveyed folks and asked about their drug use and their goals and their priorities. And what we learned was that 57% of people with high-risk alcohol use and 68% of people with high-risk drug use told us that they wanted to cut back or quit. And this was just on a simple survey, not with motivational interviewing or other effort. People also told us they wanted medication for addiction treatment and that they wanted it to start in the hospital. They affirmed what we knew, which was that there was a gap time to treatment in the community. So if we were going to start people on medicines like methadone or buprenorphine and then give them a follow-up that would be in 2 or 3 weeks, that was a problem. And we knew that, but hearing that from patients was really important. And the other thing patients told us loud and clear was that they really valued treatment choice and that they wanted providers that understood substance use disorder. This is a quote that I found so compelling, and I'll share with you from one of our patients in that early needs assessment, describing most of us that do it, and it being their drug use, can't stand it. I hate the stuff. It's wretched. It's like damned if you do, damned if you don't. When I do it, I don't even feel good anymore. Like it takes so much just to be okay, to be normal. It's like when I use, I just feel normal. So they, referring to hospital staff, don't understand that. So again, we were doing this needs assessment to understand from a patient perspective what was the need. And then we also needed to collect data to convince stakeholders that they should invest in change. And so we did some work to define a business case. And this is a figure from one of our this early study. And I'm just going to walk you through this briefly. Each dot here represents an individual that participated in our study. And what we did was we graphed their expected hospital length of stay versus their actual length of stay. And this black line here is the line of identity. So if people were staying in the hospital for the amount of time that we would expect based on their health condition, each individual would cluster along this line. And what you see instead is that people's length of stay far exceeded the expected. And this is not the case for all comers at OHSU. And then particularly when we looked at patients needing prolonged IV antibiotics, osteomyelitis, endocarditis, you can see that these folks had the longest length of stay compared to what was expected. And we actually excluded several outliers as part of this. So again, with this cohort that we randomly sampled to participate in the needs assessment, they had a longer than expected hospital length of stay, which was very important for hospital leadership in terms of financial priorities. And they had really frequent high cost utilization. So just for logistical reasons, we only included the first 165 patients that we surveyed, and of those there were 137 readmissions over a mean observation period of 4.5 months. So again, very high utilization, yet not engaged in addictions care, and that we were really effectively not serving. So what did we do? So we took these findings from the needs assessment and we mapped them to components of the impact intervention. We did this collaboratively with partners from across the region, and so I just show here kind of again, the array of organizations and folks. This is really a team effort. And we developed impact. This is a picture of I walked into one of our impact patients' rooms. Again, you can see the top of the tram here, and our patient had just met with one of our impact peers, and on her window written, "I am worth recovery." But our team, based on this needs assessment, includes a consult service comprised of physicians who are all addiction medicine boarded, a nurse practitioner and PA, social workers with expertise in addiction medicine, and peers with lived experience in recovery. And what we do is we meet people during hospitalization, we provide comprehensive substance use disorder care, and really ground that care in principles of harm reduction and trauma-informed care. And we support rapid access pathways to community substance use care, including treatment, including harm reduction services, and also really a whole array of services, including connecting folks with primary care and housing services, et cetera. So now I'm going to talk a little bit about what are some of our outcomes and what is the effective impact. So since we've started, we've served over 2,800 medically and socially complex adults. 60% experience homelessness, about 80% have Oregon Medicaid, very high rates of polysubstance use, which I think really is the norm. And you can see the breakdown here of opioids, alcohol, and methamphetamines. We don't have a huge cocaine problem in Oregon. Methamphetamine is the predominant stimulant. And I don't have data on benzodiazepines, but that's a rising issue in our area as well. So in terms of our outcomes, one of the big things that we found is that through hospital-based addictions care, we're able to engage hard-to-reach populations. And this is one study that we did looking at 401 impact patients who had an alcohol and or opioid use disorder. And again, just sort of data confirming what I've been saying, which is 87% of them were not on medication, which really is the most supported most evidence-based treatment. 87% were not on medication at the time of hospitalization. And of those 87%, 74% started medication for opioid and or alcohol use during their impact admission. When we look at association with initiating medication, people who are experiencing homelessness, people who had a partner with substance use, and then also for people with co-occurring methamphetamine use, all of these folks were more likely to initiate medication in the hospital. And there are other studies that show similar findings. Nordic and colleagues just published a paper with some, I think, really aligned results from their study which I believe was at Hopkins. So again, really speaking to the reachability of hospitalization and also the vulnerability of the folks that we're serving. So I'm not going to walk through all of our studies or the literature base in general, but I will acknowledge that in general, addiction consult services, and much of this is from our team, have the potential to increase initiation of medication for opioid and alcohol use disorders and increased post-hospital engagement in substance use disorder treatment. We did a study at OHSU showing that about 17% of people were engaged in treatment before, and when we propensity matched our impact cohort to others with Oregon Medicaid, we found over 2 times odds of sustained treatment engagement after discharge. Addiction consult services can reduce post-discharge substance use, reduce severity of substance use disorders, increase patient trust in physicians and other healthcare staff, reduce harms of use, and improve mortality. And the other thing that we're finding and others are finding is that consult services can improve hospital settings that care for people who use drugs. I'm going to just share a few quotes because I think some of these stories are best told really in the voices of our patients and providers. This is from a qualitative study that we did looking at care before and after impact. And before impact, care was chaotic and reactive and very emotionally draining and time-consuming for staff. We have a patient advocate nurse role at OHSU. Patient advocate described providers get called to the unit because the person's yelling and throwing things or comes back after being gone for a long period and appears impaired. It often blows up and they get discharged or they leave against medical advice or they go out and don't come back. We don't really know what happened to them, and they're vulnerable and the staff are vulnerable and other patients are distressed by the disruption and commotion. Also, before impact, there really was a widespread sense of futility, frustration, and everybody kind of getting spun up in care. And as one of the cardiac surgeons described, patients ended up either dead or reinfected. Nobody wanted to do stuff because we felt it was futile. Well, of course it's futile. You're basically trying to fix the symptoms. It's like having a leaky roof and just running around with a bunch of buckets, which is like surgery. Got to fix the roof. Otherwise, they'll continue to inject bacteria into their bodies. So again, this sense of sort of chaos and frustration before having the appropriate and necessary services. And what we found was that impact really alleviated this widespread distress. And as one of our nurses describing care with impact, you feel more empowered when you've got the right medication, the knowledge, and you feel like you've got the resources. You actually feel like you're making a difference. We also heard repeatedly this idea of legitimizing addiction as a treatable condition. And as our cardiac surgeon, or different cardiac surgeons said, instead of treating these people and making value judgments around them, now we make diagnoses like how bad is their infection, how bad is their addiction, as opposed to just bucketing them, oh, these are a bunch of addicted people, they'll never get better. And finally, I think that an addiction consult service and implementing this care in hospitals really has potential to heal the system. And this is a quote from a different study where one of our impact physicians described this is an institution. And so often I feel like the peers will show us the ways in which institutions can either harm patients or not hear patients. Those are the conflicts that our patients also experience. We just don't have to see it when we're the ones with the power. And I think this is so important, very reassuringly in recent years, there's been a lot of emphasis at OHSU and hospitals around the nation to think about health equity. I think this is a real way to promote health equity through this kind of work. So I've talked to you about my story a little bit about how my story has changed OHSU's story, and now I want to talk about some of the ways in which we're hoping to support change across the United States. And this is a photo of Mount Hood. So one of the things that our team at OHSU is doing is we have an ECHO, which is a telementoring program. We run a 12-week ECHO series and include an interprofessional faculty as well as interprofessional providers. And we started with Oregon hospitals. We've now expanded to include folks from around the country, and you all are invited to participate in our ECHO if you're interested. And it's been a really very fun and interesting experience and really informed how I think about some of the changes that we need. And it's remarkable how some of the struggles at rural and frontier hospitals are reflected even in big urban hospitals. And of course, each site has its own unique challenges. And then we're also partnering with the NIDA Clinical Trials Network to lead a study of hospital-based opioid treatment in hospitals around the country. But in doing this work, one of the things that I think is so important is that we're really working to reframe how hospitals address addiction. And so historically, I'm just comparing to other common conditions with diabetes, we offer people insulin and we recommend dietary changes. With acute myocardial infarction and cardiac disease, we offer aspirin, statin, and other evidence-based treatments. Whereas really the norm in hospitals is with addiction, we tell people to stop. However, what's more appropriate and what's evidence-based is we offer people medication, we offer naloxone, we engage and link people to care. So I want to spend sort of the next piece of this talk just talking about some of the strengths, opportunities, and lessons learned specifically about addiction consult services. And one of the things is that consult services can drive clinical innovation. And there's a number of areas where this has happened, and it's part of the fun and excitement of being a part of a team like this. For example, our past best practice was to start buprenorphine inductions where people had to be in acute opioid withdrawal in order to initiate this medication. And now we do low-dose buprenorphine inductions, and we can do them rapidly over a couple days, or we do them slower over a couple weeks. And Dr. Thakrar here has led a very successful national workshop about best practices in this. But again, it's really changed practice. Another area where we're sort of driving change is in the era of fentanyl, methadone. We used to start methadone and we would do it relatively conservatively, 40 milligrams, and then sort of go up slowly over several weeks. And it was tough, and we didn't offer much support around craving and withdrawal outside of that. And now, we go much more quickly. And so on day one, we'll give 40 to 50 milligrams, and we ramp up by 10 milligrams every couple days. Similarly, we'll prescribe full agonists for pain and withdrawal. And then, benzodiazepine management is a whole other area. So again, addiction consult services really can be a way to drive excellence and keep up with practice that I think is beyond what a generalist can do. Consult services also respond to emerging population health needs. So in COVID, our consult service and other consult services really mobilized to provide all kinds of necessary care. As everyone was shifting to telehealth, our patients don't have phones. And so we needed to appeal to hospital leadership and Medicaid payers to say, hey, this is a big problem. We need to be able to meet people's needs in real time. Others coordinated with COVID isolation and recovery units, informed visitor policies, et cetera. And it's also not only in the context of COVID, but climate change and extreme cold and heat. We had a botulism outbreak recently, and it was our consult service that was actually driving the state response to sort of triggering this awareness. And then other efforts around harm reduction, around safe supply or risks of the drug supply, and addressing those. Consult services also promote systems-wide substance use disorder education and support best practice. And I really argue that integrating addictions care in hospitals, which are the training grounds for all health professionals, is so critical to having a prepared workforce and so critical to our meeting this enormous national need. And unfortunately, I think that unprepared systems perpetuate stigma. And just as Dr. Perron said in her introduction, there really is a duty for academic medicine to step up. And Dr. Nora Volkow wrote a piece saying as much recently. And what we're also finding is that a consult service really can build capacity across the health system for some basic competencies in addiction medicine, which are so critical to our addressing the mortality rates and really helping support people to engage in care. Consult services can partner for improvement and equity across the clinical enterprise. We partner closely with our infectious disease teams, with our cardiac surgery teams. We have ongoing work developing new approaches to care with trauma surgery, palliative care, our perinatal best practices. So again, really as kind of a platform and driver of local innovation. And then I want to speak briefly to some of the arguments around cost effectiveness and cost savings. Consult services have potential to reduce length of stay and reduce avoidable readmissions. Some data from our team, we looked at patients who we partnered to develop this interdisciplinary care conference with infectious diseases, where the sort of baseline standard of care and usual practice was that anybody needing IV antibiotics would stay in the hospital or be recommended to stay in the hospital. And we had a lot of challenges with that because not all patients wanted to be in the hospital, could stay in the hospital, et cetera. And so now we really have a much more standard approach where we weigh risks and we weigh protective factors, and we support people to get the care that's much more patient-centered. And what we've found with that is that it also is cost savings. And so with our first patients who underwent this process and worked closely with our teams, we observed 603 out-of-hospital antibiotic stays. And that has been foundational to some of the aspects of our business case around just increasing bed capacity and throughput. And I think how these conversations are framed around the business case are sort of tailored to the individual hospital where the opportunities may be. There's also, as I shared with some of our earlier data, an opportunity to increase physical and behavioral health integration, and in particular, the HEDIS measure of substance use disorder treatment and initiation and engagement is a quality measure in Oregon for our Medicaid payers. And so because of that, and really largely because they believe in the work and see the value in the work, we've partnered with them to develop case rates which support our financial bottom line and really make a big difference in our ability to deliver the care. And then the other opportunity around sort of cost is not only the financial cost, but the moral distress, which does translate to financial cost as we're struggling to maintain a workforce. And so I think we have not done this, but there are ways to put dollars and cents around some of this non-productive staff time. So the last sort of main thing that I think want to highlight of what addiction consult services can do is to lead with science and not stigma. And I want to share a story of a patient who I cared for, and her story is really close to my heart. She was a 29-year-old woman when I met her in 2020. With an advanced methamphetamine-induced cardiomyopathy. And I met her early in her hospital course. She met criteria for a severe methamphetamine use disorder. She was admitted in advanced heart failure. She smoked methamphetamine, had no injection use. She shared with me really strong motivation to disrupt her use and had last used methamphetamine a couple of weeks before hospitalization. She had strong family support, and she had recently moved from one rural area of rural Oregon to another so that she could be closer to family. So she now had a secure living environment, and she got quite tearful when talking about her motivation to disrupt her use, largely to parent her 8-year-old son. And her hospital course was a lot, and she developed progressive cardiogenic shock despite diuresis and despite inotropic support. And from the get-go, cardiology felt like for her to be a candidate for home inotropic therapy, she would need 2 months of sobriety. And she really was not responding to that inotropic support. And they were clear that she would need 6 months of sobriety before she would even be considered for a ventricular assist device or a VAD or for a heart transplant. And so it was sort of recommended that she go home with hospice. And we worked with her and continued to support her. She was highly engaged with our team, including doing a lot of recovery work with our social worker, including working closely with our peer. And as we worked with her, it just felt like there was a lot of stigma that was driving these decisions. There was also no evidence to guide how to support someone like this, but we kept working with her, kept the conversations going. And on hospital day 42, I'm delighted to say that she did have a ventricular assist device placed and she was discharged to home. And I just spoke to her this morning, and she had 499 days after her VAD. She did undergo a heart transplant. She's actually discharging from the hospital, and I asked her permission to share her story with all of you, and she said, of course. But this is a young woman who, at the age of 29, was going to be discharged home with hospice, who is now parenting, who has got a sustained recovery and is doing beautifully. So looking ahead, I just want to sort of ground us in a few things. One is that substance use disorder drives high morbidity and mortality. We are having unprecedented overdose deaths in this country, and as I said earlier, overdoses really represent the tip of the iceberg. We know that substance use disorder overdose deaths cost the U.S. More than $1 trillion. This is actually data from opioid use disorder alone from 2017, so I think it's likely much higher. And we also know that hospitals have skin in the game, and despite this skin in the game, most hospitals are getting predictably poor outcomes. So I think it begs the question, what do we need to do to change the standard of care, and what is holding us back? And I think that it's really one thing that we should at least acknowledge is that there's individual and structural stigma. The lack of prepared systems really are both cause and consequence of our system failures. And I like to assert that one way to undercut this stigma and improve systems is to make a visible commitment. And my hope is that at a policy level, we make an even more widespread and concerted commitment so that we can make this easier for hospitals to do. But I think there's a number of ways that we can start to address this. And so one is with clinical care and care models like addiction consult services. Another is through change policies and metrics to really incentivize better care. And some of those policies are thinking about our, very punitive and restrictive hospital policies, and some of those are broader policies. I also think metrics are really important, and that there's a role for reporting, publicly reporting some of, just like with door to balloon time for acute coronary syndrome, we could report rates of initiation of medication for opioid use disorder, for example. Clearly, there's a need for research to expand and improve how we integrate evidence-based care into these settings. There's a need for widespread education, both to support delivery of these care models, and then also that education is a critical piece of what a consult service can help accomplish. We need community partnerships and diverse voices, including voices of people with lived experience. And we need funding and incentives. And I think that funding can and should come from individual hospitals. I also think that we have a need for broader sources of funding beyond individual hospitals that hopefully will be coming down the road. But I don't think we can wait. And last, to support all of this, we need strong leadership. So I will leave a bit with a call to action, and as all of us, to think about what is the role for, and many of us wear multiple hats, but what is the role for clinicians, for hospital leaders, for hospital organizations, and for governmental organizations and payers to move the needle, because it's all doable. So with that, I will open it up for questions momentarily. I wanted to share one last, this is a whiteboard from one of our early impact patients who had a really tough go of it in the hospital and then has done beautifully. So I really like this quote. I want to leave you with just a few resources. Some of these resources are for patients and families, including the SAMHSA Treatment Locator, the Harm Reduction Coalition. I put a link to our ECHO, and then PCSS, or the Provider Clinical Support System, provides a lot of training that can be very useful. And just a reminder to folks to carry naloxone. I tell people carry it in your purse, your diaper bag, your carry-on, because you never know when you might need to use it. Put all my references here, and I'm happy to share the slides. And with that, I will close. I want to acknowledge our impact patients and families, the really tremendous interprofessional clinical and research team that I have the opportunity to work with and lead, OHSU Hospital, our Department of Medicine, and Hospital Medicine and General Medicine, and then our Medicaid payers. And these are my two little guys from about a year ago. They're now 5 and almost 4. And that'll do it. Thank you so much.
Thank you so much, Honora. I know we're going to have a rich discussion, and I appreciate all of your comments because we really have been grappling with a lot of these same questions. We know there are individual patient stories, and we're trying to, convey those patient stories to leadership. So I'll just open it up for anyone to unmute and ask a question. There were a couple in the chat. Shoshi, if you want to ask your question.
Sure. Thanks, Jean Marie. Thank you so much for this fabulous presentation. I really enjoyed it. My question, I was just curious because you had mentioned who was on the impact team, and I was curious about any RN participation on the team. I know I'm a nurse practitioner, and something I hear anecdotally from many of my patients in my OUD clinic after they've been hospitalized is often that the nursing care can sort of make or break their experience in the hospital. Because, nurses spend so much time with patients. And so that's something that I'm really interested in and excited about all these addiction consult services and wondering how RNs can be involved.
Thank you so much. What a great question. And it's nice to connect with you in this space. I think you have a very nice Twitter voice, if I'm remembering right. But a couple of things. So one, as our sort of original model, is the model that I shared, and we didn't have a formal nurse role. We do have nurse champions who become part of our sort of weekly structure as we huddle as a team daily, and then we have a weekly operations meeting. Our nurse champions come to that weekly operations meeting and are really instrumental and have done, and then as part of our ECHO faculty, we have a nurse as part of that faculty. And actually have had surprisingly and delightfully really robust participation in our OHSU ECHO from OHSU nurses, which I was not expecting. We really designed it much more for our community, more rural community hospitals, but they've been great participants. So you're absolutely right that they're a critically important part of this interprofessional team. We're starting 2 projects. We're going to have an impact nurse who will have a harm reduction role starting soon, that will really be focused on harm reduction education and potentially, though I haven't gotten the full green light for this, some safe supply distribution in the hospital. And then we're also starting a contingency management pilot, and we're going to have a nurse formally as part of that. It's going to be an app-based pilot. We'll see how it goes. So some new work. We do have a nurse practitioner who is a total gem and essential part of what we do. But I think the RN piece is huge.
That's really exciting to hear. Thank you.
Thank you.
And I think there's similar questions from a couple different people in the chat, but one is from Rob Stetson, who's been working closely with us on the finance. Did you face stiff headwinds from your hospital administrators when you first started Impact? If so, how did you convince them?
Thank you. It's a great question. So there was a lot of scrutiny, and some of that was from administrators for sure. I think part of why we were able to do it was that figure that I showed, showing the actual versus expected length of stay, and really just being able to show the hospital that they were already investing enormous resources in this care and getting such predictably poor outcomes. And so showing the rates of high utilization, showing the high readmission rates. All of that was part of the story. And then telling the patient narrative was so critical, and telling the staff narrative was important as well. I had done other work that I led before this around hospital to home transitions of care, and had also developed good working relationships with executive leaders. And I think that that was part of why we were able to be successful, was that I had already kind of a proven track record of success. And so there was a level at which I think that the executive team knew and trusted me that also really helped.
Thanks. And then Peggy Compton, who's a nurse researcher, mentioned a metric I didn't hear you speak to was patient-directed discharges. Can you speak to the impact on AMA?
I can, and I think Peggy is another name whose papers I have read. This is kind of fun to see all
Absolutely.
of you guys. It's a really small crew. So thank you for that work. Yes, so we've not measured it, but I can tell you anecdotally, and unfortunately I took a slide out describing a quote. But anyway, basically the quote said, left AMA, left AMA, left AMA, AMA. Of course they were leaving AMA because we weren't treating their withdrawal and we weren't treating their pain. And so we, again, I don't have actual numbers on it, but I know that there are sort of from non-OHSU data, hospitals tend to have high AMA rates in this patient population. I can sort of tell you anecdotally that I think we've been able to make a difference there. Also around code greens for some of our patients, which at OHSU is the sort of code that gets called when there's a lot of behavioral outbursts. Some of our, kind of most beloved patients are some of the folks who've caused the most disruption, and we do a lot of work and have a dot phrase around de-escalation for staff, and do a lot of anticipatory work. Every time I'm seeing somebody in the ED, I ask them about what might be triggering for them in the hospital, and do they have any substances on their person, and here's the sharps box, and is there anybody who shouldn't come and visit you when you're in the hospital because it might be hard for you, or it might help, it might make staff feel uncomfortable. And we kind of just talk about that up front, and I think it really helps people stay. Our peers are huge for staying in the hospital. They do a lot of work just bringing people activities and coloring books, and so anyway, that's kind of a diffuse answer to your question.
Thank you. Maggie, you want to unmute and ask your question?
Sure, I realize it may not even make sense in the chat. So yeah, I'm curious because you put the expected length of stay versus actual length of stay. I think that's super compelling, but I know also that some of what happens in the hospital is, with the addiction consult service is actually that people stay, and that length of stay may not change, and sort of how, but hopefully like downstream effects do. And I'm curious sort of how you had some of those conversations with leadership as we think about how, again, to make the argument here and support that.
Yeah, it's such a good question. And I think, even looking at that figure, there's some people who had a much shorter length of stay, and you can sort of pick out who you would guess would be folks who left against medical advice. We have collected data that's really more kind of administrative data and probably wouldn't meet the muster of peer review about length of stay reduction. And what we do is we look and say, if somebody's anticipated antibiotic end date is X date, and we were able to support them with a plan that was a patient-centered plan to leave 4 weeks before that, we have documented evidence that they completed their antibiotic course. And we don't talk about it as days saved because a little bit of just the verbiage is different, but those out of hospital antibiotic days we just sort of, again, for making our pro forma, we just kind of take a rough cut and say, what if 50% of those were days saved, which I think is actually a conservative estimate. And then we can kind of build a case around that. So I don't know did I answer your question? Kind of?
No, that's helpful, because I think it is this like conundrum of like, actually by providing better care, we may be lengthening some of that. And I think, I think Judy's question builds on it nicely, because, we have to make the financial case sort of, but also we really just want to provide good care.
Yeah, I'm happy to come off.
Oh, sorry. Hi, this is an awesome lecture. I'm Kit. Delgado. I helped run the opioid task force with Maggie and Jim Marie and others. And I was going to ask the same thing because on the length of stay, because I would imagine when we talk to our hospital administrators, like you know that these patients are in the mostly poor payer mix, and so I don't think they're convinced by length of stay, and reducing length of stay is like a good metric. But I would imagine that reducing readmissions and return ED visits is sort of viewed favorably by them. But the other one I think I saw in your deck was about treatment engagement, and this is sort of in our system, how to measure that after they leave the hospital. This is a challenge because folks follow up in our system, but also outside of our system, and I'm just curious how you measure how patients do once they leave the hospital, and how you measure treatment engagement after the hospital.
Totally. Thanks for that question. Around the length of stay, I will say one other thing, and then I can talk to you about the treatment engagement. At least at OHSU, around financial drivers, if somebody's has a planned length of stay of 6 weeks and they leave after 2 weeks, then that's 4 weeks where a different patient can, because of DRG-based payments, that's 4 weeks where somebody else can be in that hospital bed. So it doesn't matter a length of stay reduction, the payer mix is less important. And I agree with you that looking at a multifaceted approach around what is the value is really where is the right way to approach this. In terms of post-hospital treatment engagement, and I'm just sort of pulling up, I can show you, whoops, I was going to show you a slide, but I'll just spare you. Well, here, let me do it, what the heck. So this is a figure from one of our studies. Can you see this?
Mm-hmm. Yes.
And this is we looked in the Medicaid data, and so we matched impact patients who had Oregon Medicaid with other patients that were not at OHSU who there was no other addiction consult services in the state. And what we saw was basically a baseline treatment engagement was similar in both groups. And then again, an adjusted odds ratio of 2.15. And so because we had Medicaid data, and our outcome here was this HEDIS measure of 2 or more encounters, or we also used medication data to determine that 34-day treatment engagement measure. I'll stop sharing. So we've done studies using Medicaid to, and I actually think if you look at OUD alone, the treatment engagement is even higher. But we felt it's really important to develop a model and develop a business case that's independent of payer type and independent of specific substance use type, because polysubstance is the norm, and we didn't want a payer-specific approach, though we are fortunate to have some of our Medicaid payers give us a case rate. But that's one way, and then the other way that we've assessed substance use severity after hospitalization is actually to survey people, and it can be a hard group to reach post-hospital, but we were able to, can't remember the final number, but we got better over time, and I think we reached over 70% of people in those phone follow-up visits, and that's how we were able to show reduced substance use severity.
Thanks. Appreciate it. It was really great. I have to run to a shift, but thank you.
Thanks.
Bye.
So a few more questions in the chat. Katie, who's part of our endocarditis team and is a social worker who's led a huddle type model, asked, sort of, despite whatever you do, how do you manage when a patient, you've done your best, still wants to leave? I think that's your question, Katie, unless you want to come off mute.
No, yeah,
clarify.
definitely. It's just,
Okay.
it's honestly still, it still like eats me alive whenever this happens. And like, it's been so much less again, since we started, like, again, a somewhat similar impact model, but it just happened recently to me. So I just, was wondering if there's any strategies or ways that your team copes when, this, inevitably happens from time to time.
Thanks for that question. I think it's so important. And I guess I'll say a couple things, and we have had a couple that really stand out. One man in particular who underwent valve replacement and then, left maybe, I don't know how many days post-op with a chest tube in, and it was really pretty traumatic. And I think actually the most traumatic maybe for our cardiac surgeon, who just feels the most responsibility of anyone on the team. And so it's hard. We do sort of create some space for reflection around process improvement. And I think those are super important conversations. The other thing that our team does, that our cardiac surgeon and our kind of interdisciplinary endocarditis team is not so much a part of, but the impact team does, is, as I said, we have these weekly meetings, and as part of our weekly meetings, actually every meeting we have, we do a quick check-in at the beginning, and people can say like, yeah, I just had a fight with somebody and I'm in a bad mood, don't take me personally. Or, sometimes it's not like a big processing thing, but our peer might share, a friend overdosed and I'm really struggling. And we have a weekly meeting where we do have more space for the team to just, it's been particularly important in COVID, to do everything from celebrate the small wins and the big wins to some of the losses. And I think that sort of hardwiring that space is so important, because just as you say, we carry these stories with us, and it's just so important. Thanks for the question.
No, thank you for that. Thank you.
Yeah, I can definitely relate, both as a team leader and we do have those losses, and it is really hard to know how to find the time and the space, especially virtually. And it's good. We should really consider how to develop that. So Sam, do you want to unmute yourself? It's similar, I think, length of stay, but about destinations for where the patient may end up.
Yeah, I was just wondering about.
Oh, we might have lost you.
Is that better?
I can hear you now. Should probably start.
Yeah, just wondering about how something that I run into at a couple different hospitals of when I start somebody on, some sort of medication for maintenance treatment, and it creates a huge dispo barrier. Or the patient says, I would like placement at a drug and alcohol rehab, and we say, great. And then it's super difficult to get them into one, and their length of stay, like, quite measurably increases because we're doing the right thing for the patient. And how your service has sort of navigated that when, if a primary team reaches out and says, because we hear this every so often, it would be so much easier if they just weren't on methadone, like they could have left 4 weeks ago, or something like that. And just how you work around that, because I hear the argument about, we're preventing readmissions, and I agree with that. It just can be hard to make that argument like in the moment when you don't know if that person would get readmitted, if that makes sense. So it's more,
Yeah, no,
we're on the same page, but how you make that argument to others.
Yeah, thanks for the question. And I would say there's sort of a couple pieces to your question, if I'm understanding right. But in terms of the just some of the limitations and challenges of linking people to the care that they most need and most want, at OHSU there were no treatment pathways when we started, so we had to, or not none, but they were quite slim. And that was for a whole variety of reasons, including there were much fewer community treatment options available, and that thankfully is improving in Oregon, though Oregon actually ranks very low in terms of community treatment access nationally. So we've done work to build out those pathways. We've also done work to support starting a low barrier buprenorphine clinic at OHSU because we didn't have enough pathways. So sort of multiple strategies there. In residential in Oregon, a lot of the residential programs don't accept people on medication treatment. And then the methadone clinics have their whole array of barriers, and in particular around skilled nursing and methadone, it's a major issue. What our approach has been in general has been to kind of acknowledge with patients up front as we're starting medicines that and as we're starting care, that we want to understand what their needs are. And I always tell people, It's really important to me to understand what matters to you and what you want, and I can promise that I'll work towards it, but I can't promise that I'll be able to make it happen. And that goes from everything to residential treatment to housing, et cetera. And so that sort of transparency, I think, can be really useful in setting expectations up front. We've also, because of the low dose bupe inductions, been able to support a lot of folks to make a transition from methadone to bupe that we previously would have struggled with. And there are folks who stay in the hospital because they need hospital care and they need methadone. And again, sometimes it's hard to know if it's the methadone or their substance use disorder that's the barrier. And sometimes the methadone, I have a talk and joke that all the gray hair on my head comes from methadone, and the limited options for methadone for people with serious medical illness. And that is like the soapbox that I will get on. It is the sword I will fall on. So it's a huge issue, and yeah, we've got work to do.
Thanks. That was a good question. We struggle with that, I think. Rachel McFadden.
Hi, thanks. Such a really inspiring presentation, Honora. Thanks for sharing with your experiences. I'm a bedside nurse, and so my question kind of has to do with, well, I really connected with that slide you shared about before impact care was chaotic and reactive and time consuming. And I think that is the perception of a lot of people in the hospital, that taking care of people with substance use disorder is that. And so I can see how a addiction service in and of itself, can change that environment or the expectation and the environment. But I'm wondering if you guys also used specific strategies to help like standardize how the care team responded to certain situations which tend to, create the chaos. And one example is in-hospital substance use or, security searches, things like that.
Thank you. Such a good question, and such a tough issue. We've done a lot, and I think, and we have so much work to do. I mean, it's not like all puppy dogs and apple pie now. Like, we still have a lot of these struggles. But we've done work around our policies, around our kind of administrative discharge policies, and we have nurse champions, as I mentioned, from that really have done just a remarkable job, so that this is rare, but a couple months ago I was on service, and a young man who I was caring for who had a history of use, a nurse had a traumatic experience where somebody had overdosed in that same room, and the nurse put a video surveillance monitor on this patient without asking for consent, and the patient was totally appropriately very upset about it. And so we had to kind of deal with that. So we sort of see these struggles as an opportunity for growth and education. And I think we have, over the years, developed support with nursing leadership so that the conversation is much less conflicted than I think it once was. So it's really a combination. It's sort of a whole bunch of things. Some of it is policy, just as you say. Some of it is just nurse education broadly. And a lot of it, I think, also is just that we tend to try to bring the nursing staff in when we're having conversations with patients, and they're often there because they're at the bedside. And I've had a lot of nurses come up to me after and say, I've never heard somebody talk to, this was early, it doesn't happen anymore as much, but a lot of the nurses saying, I've never actually heard that kind of a conversation with a person who's using drugs. And so that kind of modeling at the bedside is, I think, again, it's not a super scalable approach, but I think it's part of what helps change. And I have had some really wonderful experiences where I just about fell out of my chair with, one of the nurses who was quite hard on me when I was a resident, kind of similarly wagging her finger at a group of residents saying, addiction's a treatable chronic condition and everybody needs to be treated with respect. And I'm just so happy. So.
That's awesome. Maybe we'll skip to Ashish just because of time. Go ahead, Ashish.
Hey, thank you so much, Jean Marie, and thanks, Honora. What an incredible presentation. Right now, we have a group of physicians, pharmacists. We help informally with complex addiction cases at Penn. People will email us, text us, and I've been part of similar groups in other hospitals, and I know this exists at many hospitals where they don't have funded consult service or experts. So my question is, do you have recommendations for how to do that kind of informal work in a way that doesn't inadvertently take pressure off hospital administration from developing sustainable and funded approaches?
What a good question. I think that you're just scratching the surface, most likely, right, in terms of the numbers of patients and your ability to really implement transformative change. And so I would sort of use it as, I would actually be as explicit as you can about partly what we're doing is we're understanding what are the local needs. And so then you're delivering a service, but you're also saying this is a group of people who's invested in this, and we can start to see through patients' eyes and through the system's eyes where things are falling short, and make sure to kind of catalog that and document that and share that so that you then become part of a needs assessment and part of a drive towards change, and not, I was talking with someone for a project that I've been working on, where a community provider is doing phone calls into the hospital and supporting pathways to care. And this is in a small rural hospital where they have no addictions care. And he said, I feel like somehow maybe I'm going to be the Band-Aid that's the reason that the hospital administration doesn't see that there's a gash underneath. And so we sort of talked about ways that he might sort of do the same kind of thing. So I think you're right to be doing it, to be doing the work, and you're right to be asking the question.
Thanks.
We've been pretty systematic about some of our routine data collection as part of any meeting that we have, where we take down notable cases. And we, again, really try to use those cases and stories to drive local change. My relationship to hospital administration and hospital leadership has changed such that I don't quite have the usual ways of then voicing some of those needs. But I do think that our approach to just trying to tell a bigger story as we go has been part of our success.
Great. I think John has a last question, and then we'll let everyone go. John, if you're still on.
Oh yeah, I was in the car for part of the presentation, but I was curious about the effectiveness of intervening on individuals with alcohol use disorder. By far, alcohol withdrawal order sets outnumber anything else in our hospital system, at least 5-1. And it seems like that would be the majority of the workload, whereas medications are somewhat modest for treating that compared to buprenorphine for opioid use disorder.
Mm-hmm. Thanks for that question. We certainly see people with alcohol use disorder and do some work there. We have also focused more on supporting the primary teams to have a little bit more comfort and confidence offering medication for alcohol use disorder, because they are comfortable and familiar with treating alcohol withdrawal. And so, again, just sort of trying to deploy our services where we're most needed. There's no way we could see, I think 1 in 9 hospitalized adults has a substance use disorder.
Right.
So we couldn't see that 1 in 9 hospitalized patients, but we're working on building systems and supporting protocols, et cetera. Another area that we do emphasize when we are working with folks with alcohol use disorder is harm reduction for alcohol use. And so talking to people about having a plan around getting home, and talking to people about not mixing substances, et cetera. So we certainly have strategies and tools, and then also build capacity within the system to improve the quality of alcohol use disorder care.
It sounds like it's been tenable to have a service that really focuses on opioid use disorder and providing education for the alcohol use disorder, because we would be swamped with that. And
Yeah,
we would miss opportunities to intervene with buprenorphine, methadone.
So I would reframe your comment. I'm agreeing with you, but I would say it a little different, which is I think we focus on complex substance use disorder, be that polysubstance use, be that opioid use, be that alcohol use. But, just as we think about kind of palliative care, every patient in the hospital needs to be able to have a code conversation, but not everybody needs a palliative care consult. So I kind of think about how we deploy our services that way. And the folks where we get the most involved, again, are some of the complex acute withdrawal, complex polysubstance use, if people have really serious co-occurring medical conditions. I haven't been able to sort of fully characterize like what is the top of that triangle of acuity that we're really honing in on. And I think that would be good work to do to better support the right referrals. But yeah, I think you're onto it. We see a lot of stimulant use here too in Oregon, and again, super high rates of polysubstance use in the hospitalized population for sure.
Thank you.
Thanks.
All right, with that, I'm just tremendously grateful, Honora's wonderful timing for all of us to understand where your work has gone and come from and is going. And we are so grateful that you came to visit with us. So thanks to everyone for joining. Thank you. And this will be recorded. It'll be on our website, and hopefully we'll be able to use it widely in our reference for these conversations. And we'll keep you posted on how we end up here.
Good luck.
Thanks,
and thank you all
everybody.
so much. Really a pleasure to join you.
Thanks for your great work.